Hello and welcome to the Rural Doctors Programme. I'm Jerry Gannon. In this broadcast we're going to be looking at eyes. Dr. Jean-Louis de Souza and Dr. Angus Turner from the Lions Eye Institute joined Olga Ward. They covered not only common problems with the eye, but the whole eye socket, including the eyelids.
Well, Angus and Jean-Louis, welcome to the program.
Thank you.
Eye injuries must surely be one of the most common acute presentations to country GPs. Could you maybe go through an initial assessment of patients with eye injuries?
I think, initially you want a good history of the type of injury to assess the potential for injury to the eye and to related structures. And you've got to remember that an injury that's occurred to the eye may also be associated with a significant head injury and other associated injuries. So life-threatening injuries are the most important thing to exclude initially. But assuming all of that's been taken care of and you're dealing with an isolated eye injury, then we go through a pretty standard history and examination procedure to determine the threat to the eye and how quickly we need to maybe seek specialist opinion or evacuation for that patient.
So what sort of things would you examine, and in what kind of order would you record them?
Well, the standard order that we would go on is a visual acuity first to assess whether there's any vision in the eye. So the standard Snellen chart would be appropriate to start with correction and with pinhole. And if patients are not able to see anything, then we'd want to determine whether they can count fingers in front of them, assess hand movement, motion, vision, or light perception. And that's the initial starting point.
Useful history of whether they could see out of the eye previously.
Well, that's always helpful, yes. And you want to test the eye in isolation, of course, to make sure that you're assessing the vision in the damaged eye and the injured eye.
Okay, so once you've done an acuity...
Well, the next thing usually we're looking for is to assess for visible signs of injury to the eye. Now, as soon as you suspect that there is a penetrating eye injury, that's all you need to do in the field setting, because from there the patient will need to be evacuated for further treatment. So with a pen light, have a good look at the anterior segment of the eye and see whether the cornea is in the normal shape and size, whether there's any protruding uveal tissue, which is pigmented tissue coming out from the eye, whether the pupil's distorted, suggesting a penetrating injury, and whether there's any signs of laceration on the scleral surface. And assuming all of that's okay, then the next step would be to examine the patient with better magnification to see if there's any other injury to anterior segment structures initially.
Angus, you go up to Karratha. Do you have all the bells and whistles up there for examining under magnification?
Yeah, most of the regional hospitals' emergency departments have a slit lamp, and so many of the GPs would be familiar with the use of the slit lamp in the emergency department. It's a bit more difficult if you're in your general practice or in a smaller community that doesn't have a slit lamp, and in that case, finding some loupes, if you have some available, or the macroscopic examination, as Jean-Louis said, with a good light is fine. And some of the classic signs are observing things like that distorted pupil, like a teardrop, or it's only really on the slit lamp that you can kind of get a clearer cross-section through the tissues, but it depends how comfortable you are with using that equipment.
I vividly remember having a patient who'd had something, must have been very small and very sharp, that had just pinged the tiniest little divot in his cornea. But it had dislocated his lens, which became immediately, well, perhaps obvious over the next few days. And he required quite extensive and repeated surgery, young man. Would there be anything that I should have picked up maybe in that very first instance when all you could see was just a tiny little dot of fluorescein on his cornea?
Well, it's hard to know because depending on the trauma, both blunt and penetrating injuries can actually cause something like a dislocation of a lens or a cataract to form. And cataracts can actually form very quickly with a trauma, depending on the integrity of the capsule of the cataract, but they can also occur over months and years. And so picking that as something needing transfer is not necessarily required unless, as Jean-Louis mentioned, the penetrating component that needs to be actually repaired and sewed back together.
Yeah. Things that are really high speed, do they ever catch you out? You know, somebody who's struck a piece of metal with a hammer or had a really high-speed piece of, well, I guess windscreen glass is pretty obvious most of the time, but those kind of small, sharp fragments that ping at very high speed, do they ever catch you out?
Oh, they're the classic thing that we need to look out for. And history, this is where the history is important. So a history of metal on metal hammering, for example, with then a red eye and maybe a tiny speck of fluorescein which represents an entry point to the eye, could be associated with an intraocular metal foreign body that could cause permanent blindness. Now, there's important medico-legal aspects in these type of histories as well. And these days in teaching hospitals, we would do CT scanning to exclude the presence of small intraocular metal foreign bodies. In the past, plain X-rays were equally good, but perhaps with the very small ones, and to localise them better, CTs are the method of choice. And the other mechanism of injury in the country, which is pretty common, is fencing wire, which also tends to go in and out and cause a small laceration and perhaps disrupt the intraocular structures and leave a very small visible sign on the surface of the eye. So these are the situations where the correlation of the vision, the associated type of injuries and the mechanism of injury should raise a suspicion and maybe result in maybe discussing the case with someone in Perth.
I mean, there is a balance between being practical because, as you would know, in these sort of mining towns or working towns where there's a lot of metal foreign bodies on the cornea, we can't bundle everyone to CT, but it's really that history and the kind of injury, because if you've taken a foreign body off the cornea that's on the superficial side, then we're not going to have to obviously worry about it going inside. But at some point, people are caught out, and these cases come up here and there.
Yeah. If something has produced like a very small metallic foreign body that's actually gone into the eye, how long have you got? Like, how quickly does that need to be seen?
They can be quite inert, and they're usually sterile as well. That's the other thing about these, because of the speed that the things come off with. But the metal, the contents of the metal can sometimes be toxic to the eye, to the retina. So depending on the nature of the material, it may need to be removed and where it's sitting in the eye. So if it hits the lens, it will cause a cataract. But I've seen patients that have had little bits of metal sitting inside the lens and quite inert for many, many years. So it depends, largely on the mechanism of injury and the type of material.
Okay. And
so
that treatment's difficult as well.
Yeah.
I mean, it's a tertiary centre.
Oh, absolutely.
Vitreoretinal surgery, lining up magnets and things that sound very fancy that I've not had much experience with.
So it sounds to me like this is something that needs specialist review, but that we could maybe phone up about and get seen a little bit down the track. Like it doesn't.
No, I'd say
this needs to be seen very quickly.
If you knew it was in there,
yeah. Well, we're often much more concerned about the globe itself, but there are often injuries to the eyelids and the surrounding kind of bony structures within the orbit. What sorts of things should we be looking out for with somebody with, I don't know, a black eye who's gone through a windscreen, for instance, or bashed into the dashboard?
I think it's the same sort of approach in terms of the history and examination and remembering the globe itself, but then thinking about the orbit. That's where further imaging and radiology helps, and the CT scan has become a sort of procedure of choice there, depending on what's available locally. And the classic cases of the blowout fractures or the weak parts of the orbit wall that may trap a muscle or cause some restriction of movement. So adding to the examination, one can add parts of the examination such as testing the sensation on the skin, being the part of the trigeminal nerve that passes over the inferior part of the orbit there. And then also aspects of eye movements, checking for the full range of eye movements and noticing that one globe won't elevate in the same way. And those are kind of suspicious features.
It's usually elevation that's the problem.
Often the floor of the orbit.
That's correct. Yeah, the floor and the medial wall are the most commonly damaged. There's only two settings really where there's urgent need for treatment, and those are if a patient has vagal symptoms on attempted eye movements because of the muscle entrapment in the orbital fractures.
Yeah.
Now that's an emergency. I mean, there are patients who can get bradycardic and asystolic episodes as a result of that. So they require urgent treatment. And a variant on that is a trapdoor type of fracture called a white-eyed blowout, which typically occurs in younger individuals, in children, where the fracture fragment traps the muscle and doesn't necessarily cause lots of bruising and even maybe a very small fracture on imaging, but the trapped muscle can become ischemic and lead to long-term problems with extraocular movements. But other than that, most orbital fractures and blowout fractures can be treated electively down the track. But we usually like the initial assessment within the first week, and the ideal time to intervene with surgical treatment's about 2 weeks after the injury. So those are patients that would need to be assessed.
So you're looking for when the swelling goes down, you
That's
can
correct,
actually do something about it.
Yeah.
Now, the last patient I saw with one of these had an orbital blowout fracture and actually was getting diplopia because of the axis of the pupils being kind of like that, where the globe had dropped. Would you have left that for 2 weeks as well?
Oh yeah, no, usually we do, yeah. And the only real indications for intervening is with large fractures, persistent diplopia after a couple of weeks, and then in some situations where there might be a cosmetic problem down the track because of enophthalmos. And again, that relates to fracture size. We tend to be a little bit more conservative, or I tend to be a bit more conservative than some of the plastic surgeons and maxillofacial surgeons who will intervene based on fracture size only within the first couple of weeks, because that's a good time to do the surgery. Several months later, it's still possible to do it, but it's much more difficult.
And checking the optic nerve is another aspect that can be affected, and the relative afferent pupil defect, or noticing the pupil involvement, is a good sign of optic nerve involvement.
Okay, now you might just need to talk us through that in baby steps.
Well, I mean, that's a good one to get your head around at some point and think it through slowly, but it's basically shining a torch on the pupil. You can shine directly on the pupil and see that direct response. It constricts, but there's also the other pupil constricting, the consensual response. And when you swing the torch to the injured eye, it now starts to dilate, even though it's got a torch on it. And that's because it still has its memory of the consensual response, but it's actually got a poor direct response. So relatively speaking, it's dilating.
Okay, so and the dilating eye will have a orbital nerve
It could involve the optic nerve, exactly. And it's not just for trauma, it's also for optic neuritis and other aspects of an old injury to the eye that's left a trauma, optic atrophy.
A little bit later in this program, we'll talk to the RFDS about transporting penetrating eye injuries. But in terms of the immediate management, do you have any kind of recommendations for the doctor who's on the ground with the patient with the lacerated eyelid and the thing sticking out of the orbit?
Well, it's a pretty scary situation to be in, and if you've identified some iris pulled out or distorted in the pupil and you believe this needs to be transferred and have liaised with someone in the city to receive, I think some of the immediate things is to not fiddle with the eye too much. Trying to learn how to use some sort of pressure device for the first time, or getting a lot of extra eye movements going on, can get difficult because it can distort tissues. So putting a shield on, not a patch, but possibly a clear shield or a cup if that's what you've got, just to stop it being injured further. And then a few other sort of primary conditions would be to worry about their tetanus and antibiotic status. You might give a prophylactic dose of an IM or IV ceftriaxone, for example, or a broad spectrum antibiotic, an antiemetic for nausea to stop vomiting, and worrying about analgesia and tetanus status. And then I think it's time to get them on the plane.
And the only other thing I'd add is if there's any foreign bodies, not to attempt removal.
Same as a knife.
Yes, so you'd have to put your shields around it if it's coming out of the orbit. And to limit eye movements, something that might be useful is to not patch the other eye, but to put a pinhole occluder on, so you can put something over the other eye with just a pinhole so they can see by looking straight ahead, and it stops movements that might cause consensual eye movements. Tends to keep the other eye straight and keep them a bit more relaxed.
Now, that's a terrific idea, because I was thinking that the patient might be really quite terrified to be absolutely blinded with both eyes covered. In terms of making a pinhole, bottom of a styrofoam cup with a pinhole, that kind of idea?
That's right, yep. Something like that, and just give them something to look straight through with, so they'll keep the eyes straight.
In terms of eye injuries, you also quite often see just blunt eye injuries. And high femurs that go along with those. Now, sometimes you just have a very fuzzy-looking anterior chamber where the blood's been jiggled around all over the place, and sometimes you get a nice level. We used to just kind of, rest them up at 45 degrees, but are there special things that we should be testing, checking, rechecking, talking about with those patients?
Knowing what the pressure's doing is maybe important in a susceptible individual. Now, fit young people will tolerate high pressures in the eye without having any significant damage to to the nerve or the circulation. But an older patient with glaucoma, for example, may not tolerate it. So there's individual variation with that. And we don't really want the intraocular pressure dropping low because the pressure tends to tamponade the bleeding. So it's good to know what it is, but we don't necessarily panic about it.
And that's just a normal applanation measurement?
Yes, something simple and not too traumatic, hopefully.
Yep.
Now, I would always give steroids, and frequent steroids are helpful. They reduce the rebleeding rate, and we get a rebleeding occurring between 3 and 5 days with clot lysis after high femur. So just as
now,
you
you're
would with
talking
any
topical steroids or oral
topical steroids are fine. Oral steroids also work, but they're rarely indicated. So most people would just use the topicals.
Okay, now GPs don't mess around with prednisolone forte very often. There's something simple like FML, or is that too weak?
No, it needs intraocular penetration. So yeah, Maxidex, dexamethasone or prednisolone. Yeah.
It's an interesting one with the pressure because it may not be present at the time of the injury, but it's one of the key things for the follow-up. So if it's being managed in the country and remaining there because it's a reason not too huge a high femur or there are not other aspects to the eye injury, having the ability to check that pressure a couple of days later as the blood's trying to clear. And everywhere is variable about what sort of instrument you might have. Some emergency departments have a tono pen that works or doesn't, and an eye care is another instrument. So being familiar with your own pressure device or the local optometrist in town who will have some good equipment for checking pressure.
Would you recommend that in any patient with, say, blunt eye trauma and a high femur that we had a quick phone conversation with an ophthalmologist?
Oh, I think so, yeah. You need to exclude coexistent intraocular injury. There is a bit of an issue with pressure if it's prolonged, if it's elevated for a prolonged period, because you can get permanent staining of the cornea. And then there are certain subgroups of patients where you want to be a bit cautious, like sickle cell disease, which might be more of an issue with some people moving into country areas now. If the sicklers particularly have significant problems with bleeding and high femurs, and for patients who rebleed, occasionally medications like tranexamic acid can be considered to stop bleeding. So, but these are usually things that are applied in a tertiary hospital setting in Perth after a few days of high femur or rebleeding that's required surgical intervention.
Yeah. And in terms of the patient with the high femur, do you just still rest them at 45 degrees? And how much resting is resting?
But from my thoughts on this is that there's not much evidence about several of the aspects of high femur management, and the bed rest to me is most useful to sort of encourage kids not to run around and get another bleed. But other people, the strict bed rest with toilet privileges only is a bit overboard in my mind.
I think so. I think that's true. That's correct. The reason for being upright is more important when they're sleeping. If you sleep supine and wake up with the clot in the pupil, then there will be no vision, and there's a potential for causing a pupillary block, which would cause a type of glaucoma. So we want that blood to layer outside the pupil, and if they're upright, we can sort of monitor the resolution of the high femur, which usually takes a few days to clear.
Finally, before we leave this section of the program, could we talk a little bit about expanding things like infections or hematomas in orbits, which are very scary for the doctor and the patient and the parents usually to watch. When do you hit the panic button, and how much treatment do you apply if you're, say, 600 kilometres from Perth?
Your expertise.
Yeah, okay. Well, I think those are conditions that we panic about straight away, even in Perth. Okay, and the risk of an expansile process going on in the orbit is that it's a contained area, and the optic nerve's at threat from a type of compartment syndrome, orbital compartment syndrome, and it's from the pressure building up behind the orbital septum. Now, the most common acute situation where that will occur is blunt trauma causing a retrobulbar hemorrhage. Yep. And sometimes the diagnosis is purely clinical, and you won't have access to imaging, and it's not relevant anyway to the treatment. If you've got a patient who looks like they've got an acute proptosis and severe pain in a very tense orbit, which you can feel, and they're losing vision in the eye, then you have to assume that optic nerve is being compromised by the pressure, and if it's not released immediately, then they will lose vision permanently. So in that situation, emergent treatment has to be given locally, and that would be a lateral canthotomy and cantholysis, which our registrars at Royal Perth very frequently talk people through in the emergency departments around the state. And it's a process that involves detaching the lower lid initially from the orbital rim to release the pressure in the orbit. We're not stopping the bleeding, but we're just releasing the initial pressure. The bleeding presumably will have stopped already at this point because of the pressure that's been achieved in the orbit.
And now that we've got emergency department video cameras in
Yes.
more than one location, presumably the ophthalmology registrar on call at the hospital might be able to talk
Hopefully
the
they
doctor
can
through
talk,
under
talk you
direct
through it.
vision.
Yes, yeah, and it's always awkward to do it in these situations because it's difficult to get local anaesthetic in, and the patients are uncomfortable, and but it has to be done.
Yeah.
Yeah. Now, in the setting of infections, it's not usually such an acute threat to the optic nerve, but there is a significant risk of secondary infections and meningitis and cerebral abscesses and things such as this. So orbital cellulitis is something that probably should be managed in a hospital with multidisciplinary teams available to ENT surgeons and possibly neurosurgeons as well, and imaging and appropriate antibiotic therapy.
Okay, so in my backyard, where I've got ceftriaxone and flagyl, probably give ceftriaxone and flagyl.
Give it. And
is that a reasonable sort of spectrum?
That is a good broad spectrum start, and you will often see an improvement after about 24 hours or 48 hours sometimes with these treatments, because it won't improve immediately, so you'll need to get that patient evacuated.
And we'll hold that discussion there for just a moment. Optometrists can be a valuable resource for you and your patients, especially in rural and remote areas. Martin Shaw is an optometrist in Belmont. He spoke with Dr. Olga Ward about the role of the optometrist, the services that they can provide, and their responsibility to their patients.
Martin, the modern role of an optometrist encompasses a little bit more than just fitting people for glasses and contact lenses. What are some of the other areas that you're involved in?
Well, really, an eye test now is far more involved. So when somebody comes in for an eye test, we will do a whole range of pre-tests. We do now retinal photography, we'll measure pressure in the eyes, we'll do an autofraction before they even get into the room. Once in the room, we'll chat to them about the medical history, their visual history. Some people will tell us about their medical history, whether we want to know it or not. So really, by the time they've got into the consulting room, the staff out the front will have asked them a lot of questions and given me an idea of what they're actually in for.
What's the difference between what you would screen and what the ophthalmologist would screen?
These days there's not a lot. So we will still screen for glaucoma, we will screen for diabetic retinopathy. With the retinal photography now, we will make sure that there's no signs of papilledema or any systemic conditions which affect the eyes. A lot of people will come here just for glasses, not realising that they might have glaucoma or cataracts. And our job really is to make sure that their visual outcome is the best for them. With the retinal photography that most optometrists do, and with the ophthalmoscopy we do, we can pick up most things. We will dilate if we don't get a clear picture. We'll dilate if we need to see the peripheral retina. So obviously if they're coming in for flashing lights, if they're coming in with spots in their vision, we need to see everything. And obviously if we pick up a retinal tear or we pick up a hemorrhage, we'll then organise for them to see an ophthalmologist as quick as they can. When the patient comes into the test room and we discuss the history with them and their medical status, we'll show them the retinal photo that's been taken as part of the pre-test. And generally we'll show them the optic nerve, we'll show them the macula, we'll show them the blood vessels, and we'll explain to them if they're healthy or if there's a problem there that we need to look a little bit further into. This particular one you'll notice has a retinal nevus, which is the kind of thing we'd get them in every 6 to 12 months to rephotograph, just so we can see if there's any change. We'll also, having the retinal photos means that we can monitor the optic nerve changes for glaucoma. The macula we can really zoom into. We can have it's a perfect way of monitoring macular degeneration. So really, with the retinal photos now, there's no need to go to an ophthalmologist to have that monitored. If it gets to the point where there's something like wet macular degeneration and it's showing up in the photos, it's affecting their vision, we'll send them straight on to an ophthalmologist for treatment.
Now, country centres are often not quite as well equipped as city optometry practices. And then quite a lot of the small towns have a travelling optometrist.
Yes.
What sort of equipment and testing can, say, the travelling optometrist do for you?
I think you'd be surprised what a travelling optometrist can do. I mean, in the hands of a good optometrist, ophthalmoscopy will still pick up most things. If you're doing it on 20 or 30 people a day, you get very good.
Yeah.
There are portable slit lamps, there are portable retinal photography units, there are things you can do. You may not get those in every town, but your average optometrist is very good at picking up problems really from just taking history and using the ophthalmoscope. Again, even in the country centre, you can still dilate and use a binocular indirect ophthalmoscope.
Yeah.
So, I mean, we'd like to think you get just as good an exam as a travelling optometrist as you would if you came into a bigger centre.
Yep. Many GPs are not trained in the use of some of this equipment. Some of us have some pretty old and slightly dodgy things like yellowing Snellen charts and you know, even an old Shiot's tonometer, and some of the other stuff that we've got. The Ishihara plates might be faded. When we're doing tests for people's driving licences, pilot licences, diving licences, how much are we doing the patient a disservice?
The most important part with those standards for the driving licences is that you're using the correct measure of acuity. All right, I do hear stories of people saying the doctor just had the chart stuck on his notice board. Really, it needs to be a 6 metre chart if you can do it. So if you can use a mirror and use a 6 metre chart, then that's optical infinity. It's going to be a lot more accurate than a 3 metre chart.
Am I 3 metres away from that mirror?
You're not exactly 3 metres, Olga. We've got you sitting a little bit closer to the mirror and the chart behind you a little bit further away. So the distance there and back to the mirror is about 2.5 metres, maybe the chart's 3.5 metres. The overall distance therefore is 6 metres. It's not hard to set up. So mark a line on the floor where your chair goes, have a fixed mirror and have the chart behind it, and that way you know everybody is the same. But certainly, you know, an old tonometer or an old slit lamp is great if a GP's got one. And I think a slit lamp would be a great tool for a country optometrist for foreign bodies and things like that. Yeah. And a slit lamp these days is not overly expensive. Some of the equipment, certainly if you keep it serviced, a Perkins tonometer or a Shiot's tonometer, it will still give a good measurement. It's certainly not as nice for the patient.
Patients with corneal conditions like keratoconus.
Yes.
Can an optometrist diagnose and treat that and fit the contact lenses, or is that something that has to go to an ophthalmologist?
Optometrists are trained in diagnosing keratoconus, which we can do with slit lamp, keratometers. Well, you have an automatic keratometer that we measure K readings on everybody, and obviously with a history taking, keratoconics, generally they start as a teenager and they've got a bit of a history of the knuckle rubbing. So we always say to the teenagers, try not to knuckle rub because it does distort the cornea if it's in that growth phase. They've got a history of atopy and allergies and things like that. As far as fitting of contact lenses go, as a general rule, it is nice to get them seen by an ophthalmologist to make sure the cornea is fit for fitting of contact lenses, but an ophthalmologist won't fit contact lenses.
Yep. And can you tell me a little bit about the new clinical training for optometrists?
Yes, a lot of optometrists now are doing ocular therapeutics training, which means they become endorsed to prescribe certain medications. They will prescribe steroids as required. They will share in the care of a glaucoma patient with an ophthalmologist. So it means you don't need to go back to an ophthalmologist every 3 or 4 months just to get the pressures measured and the fields done and the medication prescribed. It also means that we'll be able to prescribe antibiotics and anti-inflammatories as well. So it's more taking antivirals, yes. It's taking the load off the ophthalmologist really, not trying to do their job for them, but more of a shared care arrangement.
And is there anything that optometrists these days absolutely don't do?
An optometrist really won't remove a foreign body unless it's sitting on the surface and we can take it off with a cotton tip. That's fine. And again, that's where the prescribing of antibiotics and anti-inflammatories will be useful, but we won't do eye surgery. If there's a hemorrhage at the back of the eye, again, we prefer to get them double checked by an ophthalmologist. All right? An optometrist can diagnose most things, but obviously we can't treat. All right? We can't do laser at the back of the eye. We can't fix a retinal detachment. Our job is to diagnose those things and get them treated appropriately. So when they go to the ophthalmologist, they're there for a particular thing. The ophthalmologist will look at the referral and just treat what we've sent them for. The ophthalmologist therefore doesn't need to do everything. They don't need to spend 40 minutes with each patient, and it frees them up to see a lot more people. So really I think it's a co-management thing.
So Martin, have you got any final comments or advice for rural doctors?
For rural doctors, make sure you've got at least the basic equipment. It doesn't have to be the newest equipment, just enough so that you can diagnose most things and know that you can send them to an optometrist or an ophthalmologist. Hopefully you've got a better idea of what an optometrist can do now. It's going to be a lot easier for the patient rather than waiting to see an ophthalmologist. Generally, even if you've got an old piece of equipment, it's better than no equipment. Trust your judgment and practice.
And our thanks to Martin Shaw for his time. Now let's get back to our discussion with Dr. D'Souza, Dr. Turner and Dr. Ward.
Well, we've had a chat about some of the eyelid and, well, some of the eye and orbit injuries. What about eyelids, which, Jean-Louis, I know you're Mr. Eyelid. Things like ectropions and entropions, have you got any tips for helping the patients out? And how do we know when they need surgery?
Well, we'll start with ectropion. So ectropion is probably the more common way for the involutional eyelid changes to manifest in this country, and that's because of actinic damage on the skin, which tends to pull the eyelid away from the eye.
Yep.
This has got very little threat to vision, but it causes either epiphora, because it pulls the punctum away from the surface of the eye, or horrible sort of crusting and recurrent conjunctivitis, because the mucosal surface of the conjunctiva gets exposed to the air, and it can ulcerate and bleed. It's just very uncomfortable. So usually ectropion repair is done for either the symptom of a watery eye, or for the discomfort that the patient's got, or for the cosmetic appearance. And in terms of alleviating those symptoms, the best thing to do is to keep the mucosa well lubricated with a lubricating ointment, such as Lacrolube or one of the paraffin ointments. And that's basically all you can do for that, I think.
Yeah, they do whinge about the blurring with the Lacrolube.
That's right, so. Yes. So you use it at night time predominantly, and during the day
eye
you
drops,
can use
eye drops.
Yeah, but if the mucosa is exposed and rotated outwards, then it's going to become quite sort of scarred and crusted, and it will be irritable.
We don't see entropions very often these days because trachoma is almost a thing of the past.
That's right. Well, I mean, cicatricial entropions are caused by trachoma and scarring on the inside of the eyelid, but we still see involutional entropions in certain patients. So sometimes the eyelid will rotate inwards rather than outwards, depending on the balance of forces on those tissues. Now, with lower lid entropions, there's perhaps more of a risk to the eye, because the inward turning eyelashes can abrade the cornea, and you can get a corneal ulcer and an infection. It's also more irritating to the surface of the eye. So temporising measures for that include using some tape to pull the lid skin away from the surface of the eye. So you can just put a piece of micropore tape or a steri-strip to pull the eyelid down. You can inject some Botox into the lower lid if you've got access to that. That will tend to stop the spastic component that rotates the eyelid in, and that will work for a few months. But generally, surgical repair is the way to correct those. And that can be a simple procedure just by passing sutures through the eyelid, which can be done in a clinic setting. But if we're doing a more formal approach, which is designed to last a bit longer, then we do a more formal correction of the eyelid anatomy to put things back into their normal position. Now, upper eyelid entropion is a much more significant problem, because the upper eyelid is the wiper. It comes across the cornea with every blink. And if the lashes in the upper eyelid are rotated inwards, there's a significant risk of long-term vision loss. And this is why people go blind in trachoma. So those need to be identified quickly, and they usually require surgical treatment. There's no simple way to alleviate that. Plucking the lashes certainly doesn't work. In the meantime, though, lubricating the eye is very important to try and minimise the trauma that's done by those abrading lashes.
So once we've actually worked out that that's what's going on, can we lubricate and pull the eyelashes out until the patient gets seen?
The only thing I'd say about pulling the lashes out is if you don't have the right equipment to do it and break them and cause stubble formation, that is far worse.
Then you've got a sharp scratcher instead of a blunt scratcher.
That's right. The long lashes taper, and the long sort of tapered end, they're quite soft on the cornea, so it takes a long time for that to abrade.
So really good quality eyebrow tweezers for those ones.
And magnification, that's the other thing. I would do that on a slit lamp. Unless you've got 10 times magnification, which is binocular like that, it's very difficult to pick out a single lash. And it's also difficult to actually diagnose it, to be honest. So it can be one of those things.
It's worth in the areas that do have, trachoma might be reducing, but there's still older patients who've had trachoma for decades, and that's when it scars is actually causing the trichitis. So that's still present. And I know on many of the trips up north per week, we might do one operation for trachoma. So as a person working in that sort of setting, it is worth looking with a torch and some loop or something to actually check that there aren't lashes touching the cornea.
Things like, while we're talking about this region, blepharoplasty. When is it not a cosmetic procedure as far as the public hospital's concerned?
The skin of the upper eyelids has to be resting on the lashes when they're looking straight ahead, and it has to be affecting their vision. And if it meets those criteria, a functional blepharoplasty can be performed.
What happens with the stroke patients? Is it an effective and useful thing for patients who've just had a unilateral facial droop?
If there's a facial weakness as a result, it's usually more a result of a peripheral nerve lesion, so an unrecovered Bell's palsy or something following parotid dissections or something like that. Then there's a lot of things that are descending on the side of the face, starting from the brow. They don't usually have a ptosis though. They have redundant skin in the upper lid, which is recruited because of the brow droop, and they often get an ectropion as well. In fact, the lid closure is usually weakened because the orbicularis muscle is closing that, which is supplied by the seventh cranial nerve. So we usually do a combination of things to restore normal anatomy, such as repairing ectropions, raising the brow with a surgical procedure, possibly removing redundant skin, and sometimes putting a static weight in the upper eyelid to help with the blinking.
Wow.
And all the meantime worrying about the cornea, so is a sort of early days, is checking with fluorescein staining and the integrity of the lid closure.
That's right, yeah.
Sure.
Because these patients don't blink very
That's
easily.
right.
So the
presumably.
lubrication of that eye.
Yeah, the surgical things are really the long-term treatment.
plan.
The short-term, you need to protect the cornea, and most of the situations like a Bell's palsy or Ramsay Hunt, you're
recover.
hoping for recovery.
With the patients, and again, country patients, extremely common skin cancers on the eyelid. You know, like quite often there'll be a little sort of inacanthus skin cancer. Usually it's a BCC, and you can just tack a little wolf graft on it, and it's done. And you know, that's something almost within the general practice field. When does the alarm bell go off?
Well, the most common eyelid skin cancers are BCCs, but we still see a percentage of SCCs, and then there are some rare adnexal tumours which are particularly nasty and have potential for metastasis. The high-risk areas for basal cell carcinoma and squamous cell carcinoma are the medial and lateral canthus because of the anatomy and the embryology of those structures. And in those locations, lesions that are not completely excised will recur at a higher rate, and they have a strong potential to involve the orbit or to spread beyond the local area, in the case of SCC, through the cranial nerves and be untreatable very quickly. So we've got a slightly different philosophy in the periocular area to management of malignancies, even non-melanoma skin cancers, in that I like to see margin control for all tumour excisions, because we don't want to be dealing with recurrences, which are usually much more invasive and potentially more aggressive subtypes when they recur because of the delay in diagnosis and the possibility of skip lesions. And once the structures beneath the skin are involved around the eye, like the orbital fat just below the septum, there is no cohesion to the way that BCCs will grow, for example.
Yep.
And then on occasion we'll need to remove the eye to get surgical clearance of a tumour that's started in the skin. So I'd be very cautious with the medial canthal ones. I would want to ensure complete eradication. If your histopathology indicates there's any residual disease, I would have a strong inclination to either resect further or to consider adjuvant therapy for that. And for squamous cell malignancies, particularly in the situation where there might be perineural invasion, they need to be treated very, very aggressively to ensure that the tumour is completely removed. Because you do have a chance of cure with the initial treatment, but anything that's recurrent may actually spread beyond the local area.
And some of those eyelids, I mean, some of the skin's all right, but as soon as you actually get on the eyelid margin, preserving that integrity and having the margins joined together well, and then realising how much tissue you need to take out is something that you'd want to have a bit of experience with before you start trying, I would imagine. So I would say the eyelid margins particularly, but when the loose skin...
Plan,
yeah, and be in touch with someone about it, yeah.
How do you protect the eye during the surgery if you are doing something close to or on the eyelid margin?
There are commercially available shields that go on, and they're usually opaque, and they're put on with either a suction mechanism. You can see them so you won't leave them behind. We have some that are available for when CO2 lasers are used, for example, for cutting skin, and there are some that are used in conjunction with radio frequency diathermy. But they're all equally effective as a barrier between your scalpel blade or your needle and the ocular surface. And it also stops the patient looking at you, which is better for them.
That would be fantastic. Yes. Do you biopsy lesions on the lid margin when you're not sure, or are you always sure?
Oh no, I biopsied one today.
Yeah. And
I
how
think
do you biopsy them? Like, obviously you can't sort of sit there with a punch biopsy and drill a little hole, or can you?
Well, I do.
You do?
Yeah, you can.
Yeah, just like a 1 mil?
Yeah, or sometimes 3 mil.
I use a 2 millimetre punch generally, and yes, the only exception is the ones that are right on the lid margin. If they're behind the lashes, it's very difficult to get a decent biopsy, and you start worrying whether you've got a representative tissue sample. Some of those I'll do a wedge
dissection. Might as well just wedge those anyway.
Yeah.
Angus, you were talking about skin cancers, sort of on the medial canthus. Tell us about nasolacrimal ducts.
Well, I mean, nasolacrimal ducts are something to be very cautious of. The two puncta lead into the lacrimal sac, and I think most of the time that in a GP setting or in emergency departments that we worry about that particularly is the trauma, and that's the kind of lid trauma that we would send on to an ophthalmologist to be able to preserve the integrity or patency of that drainage system. But when it comes to skin tumours in that area, again, I think it's something that's quite good to handball to ophthalmology because of the lack of tissue and mobility. There's little laxity of the skin there. And if you've got any doubts about involving that region, I think I'll be sending them to Jean-Louis.
If the duct is just blocked, which seems to be a very common thing, I guess, in babies more than anything, how do you unblock it?
Well, the babies, it's a very common presentation actually, and many parents will come with a referral concerned about the watery eye, and most people will recover spontaneously within a year. So the conservative approach seems to be a very reasonable one in the first year. But after that, there's a simple probing that can be performed with a nasolacrimal probe that is used in a very short GA for the child. And the setting where that becomes difficult is whether the local hospital will have facilities to do that procedure with the anaesthetic component or the sedation. After that, it becomes quite complicated and then becomes a tertiary referral.
But for the simple unblocking, it's mostly just the standard kind of eye drops. I mean, women use breast milk, but I'm pretty sure that's just because it's sterile, warm and convenient. And just massaging?
Yeah, massaging can help. What's your advice?
Yes, massage has been shown to be beneficial. It increases the hydrostatic pressure. Mechanism slightly different in children. It's a valve at the base of the nasolacrimal duct that hasn't fully opened. So just putting the pressure on the sac in a repeated manner is sometimes enough to encourage that to open, and the probing works very effectively in children. But adults with acquired nasolacrimal duct obstructions have a much different pathophysiology, which doesn't respond to that sort of treatment. So we're looking at bypass surgery.
Yeah, and we're probably not putting breast milk in their eyes.
No, that's right.
Well, while we're in that area, blepharitis, common.
Very common.
Very bloody annoying.
I have it.
Are we still using baby shampoo?
Well, I mean, the approach for that is my discussion with the patient is that it's a long-term condition and quite common, and not to expect it to be fixed in weeks or days, and it might actually be a long-term chronic condition. So managing the symptoms and understanding what the process is can help the patient, and having a few lubrication options and talking about lid hygiene. But it depends on the type of blepharitis, and I think unless you have a slit lamp, trying to work all that out is difficult. But I've certainly suggested to many patients putting some Baby Johnson's shampoo, not the oil, on the finger and actually massaging and warm compresses. And we still discuss this with patients. The patient will keep using it if it helps, but I'm sure some of them might decide it doesn't help.
What is it?
No.
Well, I mean, it falls into a big category called meibomian gland dysfunction, where the oil-secreting glands in the tarsus become obstructed, and the lack of those oily secretions on the tear film cause an unstable tear film, which breaks up between blinks and causes symptoms of dryness and irritation. And the trapped oils are quite inflammatory, and once they get outside the glands, they can cause quite a bit of inflammation in the lid margin. And that oil build-up on the surface can also promote growth of certain types of bacteria, so you can get imbalances in the bacterial flora on the surface of the eyelids. So all of these treatments are designed to mechanically improve the flow of those glands, which are normally under hormonal control. So there are some times where the glandular secretions will become a little bit more viscous and potentially block up. Heating the glands, heating the eyelid tissue will make that more viscous, and massage will encourage the glands to flow. And the surfactants, the properties of the baby shampoo break down the oils. Bicarb will do a similar thing. So if you can get a pinch of bicarb in a few hundred mils of water and use that as a solution.
Yeah.
And then there's commercially available solutions as well, such as lid care. And there's one called Sterilid, which has a antiseptic property as well, which we will often prescribe if patients have got particularly grotty eyelids and need to have intraocular surgery in the imminent future. So those are all options. And then depending on how much inflammation is present, sometimes anti-inflammatory treatments, or oral doxycycline or tetracyclines, both for the antibiotic and anti-inflammatory properties of those medications. So
it's actually quite a complicated,
It can be, yeah, and it needs a bit of
complex
thought,
problem. Not just a bit of dandruff.
yeah.
Jean-Louis, you were talking about unstable tear films. This is something that comes back on ophthalmologist letters to me all the time. What is an unstable tear film and how do you make it stable?
Right. The tear film's actually quite complicated, and recently it's just been upgraded to 5 layers, I think.
Yeah.
So
It was 3 and then down to 10, back to 5.
Yeah. So the surface of the eye is an epithelial lining, which then has a coating of mucus on it, which allows liquid to stick to it. Then there's an aqueous layer, which is very thick and produced by the lacrimal glands. And then on top of that, there's a lipid layer, which reduces evaporation very significantly, something like 90%. And that's the secretions from the meibomium glands and the glands of Zeiss, or the oil-secreting glands in the eyelids. Now, if there's inadequate or improper ratios of these different layers, and it is a layer normally, what will happen is that instead of sitting as a layer of continuous fluid over the surface of the cornea, you'll get weak spots in the tear film which break down, and over those spots the cornea will dry. And so we'll see patients who can obviously have enough tears and they're tearing or maybe making reflex tears because the eye's so dry. But what's happening is that in between their blinks, and you have to have several seconds between blinks to read or watch television or do what you're doing, the eyes are becoming quite dry. And that is a poor quality tear film rather than a lack of quantity of tear production, for example. And it might not be a problem with the lacrimal gland. You might not have an eye that can't make enough tears. It might just be that the oily component of the tear film is inadequate. So we have to assess where the problem is. And generally those patients with poor quality tear film and rapid tear breakup require an improvement in the oily component of the tear film, for which we've, until recently, have had very little in the way of therapeutic options, but there are more things on the market that seem to...
So make us some suggestions.
Well, some dietary supplementation has been suggested, such as fish oil and flaxseed oil, and
big doses.
Big doses, though, and that's the thing that's difficult. And some people report good improvements, but having 6 fish oil tablets is quite difficult for anyone and expensive. And then using the sort of mechanical things mentioned, but then there's an array of lubricants, and what I'm quite amazed at is how many patients go to the chemist or pharmacist and pick up all the red eye ones. Yep. And those are the ones that we'd encourage people not to use. The ones that have a big red eye on the box, or say they have a component that actually constricts the vessels.
Yeah.
And so yes, they are effective in the short term to make your eyes look less red, but over the long term, these particular vasoconstrictor drops tend to end up having a kind of they become resistant basically and end up more red. So using the simple lubricants, and there's a whole variety, I just use Refresh liquid gel or Cystane or Hylofort and all sorts of different ones, but they don't have this constrictor in them, which seems to be the most common one handed over the counter.
And all of these eye drops do have chemical properties that encourage stabilisation of the tear film, but there's only a few that will actually supplement the lipids. So there's a spray called Tears Again spray, which is sprayed on the closed eye, which adds lipids to the tear film. And there are some eye drops that now have liposomal components to them, which theoretically at least stabilise the tear film. So if someone's got a tear stability problem, those might be more appropriate treatments.
Okay, so what do we write down? Because obviously you don't often write a prescription for these things. They're over the counter, yeah?
You'll have to maybe go and try a couple yourself.
Dear chemist, want one with a liposomal component. Is there an ingredient that we can tell them to look out for?
Probably the best ones are the ones with carmelose in them. They're the long chain sugars that stabilise the tear film. Yeah. And the only other thing I would suggest is that if someone's using drops very frequently, more than 6 times a day, that they use preservative-free drops.
The little mini ones you can buy, a little bit expensive.
Yeah.
But you can use them a couple of times and chuck them away. and that can be used as an ornament as much as you like.
Well, we've covered an awful lot of topics. Thank you very much for joining us today.
It's a pleasure.
Thank you.
And our thanks to Dr. Jean-Louis de Souza, Dr. Angus Turner for their time. Well, finally today, we visited the Royal Flying Doctor Service Base in Jandakot and spoke with Medical Director of the RFDS in WA, Dr. Stephen Langford. And he talked us through the pitfalls and potential problems we should be aware of when prepping a patient with a penetrating eye injury for air transport.
Stephen, welcome to the program.
Hi, Olga.
Stephen, patients with eye and facial injuries often need to be transported to tertiary hospitals by air. What sort of things should we particularly look out for?
Well, look, first thing is you refer them to the RFDS for air transport because that's what we do. But there's a number of key features just in the initial management of the patient that a country doctor needs to look at before they even put them on our aircraft.
Yep.
And I guess they're all the basics of firstly diagnosing the injury. Is it an actual laceration and an open globe injury, or is it just a minor sort of corneal laceration or ulcer? There's some real key, I suppose, first aid and early management tips that we give, and the first thing is if there's a foreign body in place, you don't remove it. It's sort of plugging the hole.
Yep.
You don't put any eye ointment in or any other drops, fluorescein. In fact, it's pretty obvious what the injury is. You don't need the fluorescein. It's important, if you can, to try to put an eye shield on. So if you've got a lacerated globe but no foreign body, at least a shield, but not a pad that's going to push on the eye. And you want to avoid any really sort of invasive examination where you put any sort of pressure which could result in collapse of the globe and loss of vitreous.
Okay, so now this patient that we've mocked up here with a stick sticking out of his orbit, would you actually shorten that piece of stick, or would you leave it sticking out to the extent that it is?
Yeah, look, that's a terrific looking injury there, but we'd actually leave that as it is because it's manageable in an ambulance, it's manageable in an aircraft. It may be a different situation if someone comes in with a metre branch out of a tree, you're going to have to snip it off, but I think that's fine. I think you're more likely to get into troubles trying to chop that off and shorten it.
All right, now that isn't done with any pressure, that's just iPads that have had a slit cut in them and stacked up and then just secured with a light bandage. How else could you stabilise and protect maybe this particular type of injury in this patient?
Look, it's pretty difficult. You've just got to use a bit of innovation depending on what the nature of the foreign body is. And as I said, if it's a laceration and an open globe but there's no foreign body, then you should be able to just put an eye shield over it and try to avoid pressure. But if there is a foreign body, you're just going to have to come up with some other innovative ways of doing things. You know, paper cups, all sorts of things come to mind.
Yes, I must admit I've seen the styrofoam cup at least cut down a little bit with somebody writing "Do not press" in very big letters just taped over the eye.
Now, look, there's some other things that are also important to do. We'd like to give the patient that they may need some analgesia. So just a small dose of something, not a big dose, but maybe a little bit of fentanyl or maybe a small dose of morphine if they're in a lot of pain. And antiemetics, very important, to try to avoid vomiting, as vomiting increases intraocular pressure and makes things worse. And ondansetron, probably fine as a normal antiemetic. It's not going to be helpful for motion sickness, but it would be good in that sense. And the other would be obviously, I think a referring doctor or someone's going to be talking to an ophthalmic surgeon about this patient, is just picking an appropriate prophylactic suite of antibiotics, because traumatic endophthalmitis can be a really nasty problem. And there may be some preferences of what's given. Some of the literature suggests quite heavy stuff, vancomycin and ceftazidime, but I'd see what the receiving surgeon preferred.
And then have a look and see what the country hospital has on Imprest and come to some kind of compromise.
That's right. And look, there's some other practical things too about the transport. We always have patients about 30 degrees up, again, to try and reduce intraocular pressure. And in this case, it's difficult because of the foreign body, but if someone had didn't have a body sticking out, we'd like to give them oxygen, because the retina is very sort of sensitive to hypoxia, and at altitude it's just maybe going to make it a little bit worse. So we'd like to give the patient some oxygen as well for the flight.
When is it important to consider trapped air in a globe or in an orbit?
Well, look, there's been a traditional teaching for about 40 or 50 years that's derived from both Vietnam and Korean wars, that if you've had a significant amount of vitreous extrude from the eye and there's trapped air, the air will expand, and then that may cause more loss of the globe contents at altitude. So typically the standard teaching is a penetrating eye we carry at sea level cabin, and we've got the capacity to do that, so we still do that at the moment.
Mm-hmm. What about the type of patient who has blunt eye trauma with a possibly dislocated lens?
Yeah, well, look, with some people have opportunities to use teleophthalmology, others just a digital camera, and may get some advice, but all the usual things in assessing a blunt eye injury, abnormality of the pupil and inability to see the retina, and consultation with an ophthalmologist, you may well determine if there's a lens dislocation, or it could be just a simple thing like a high femur. Now, my view is that a simple high femur with no other deeper injuries is probably best treated by rest and not transport or bouncing the patient around, but it's going to depend on the advice you get from a specialist.
Yeah, and I guess there are other injuries. If you are considering like a patient with a head injury, a facial injury and a high femur, then what would you specifically do for that patient who does have to be transported?
Well, look, we have to, I suppose, take the ocular injuries in the context of everything else. And, if this patient had a serious head injury as well, we're going to be struggling to try and work out how to intubate him around the stick. And we're going to manage, I guess, the life-threatening injuries first, but do everything we can, obviously, to preserve the eye.
Once the patient's got an airway secured on the ground before they get into the aeroplane, can you then, you can tilt them up then and transport them in this kind of position?
Oh, absolutely. Most of our ventilator patients we would transport, at 15, 20 degree head up tilt anyway. It's just better for ventilating most patients. It's quite easy. It's how you see them in intensive care. Yep.
And apart from considering antiemetics, do you sedate patients in this kind of situation?
Look, not necessarily. I mean, I suppose it depends on the level of anxiety and comfort of the patient. You might find perhaps a teenager or a young child is really distressed, and a very small dose of a benzo might just allay their anxiety. Yes, some midazolam, but I think you've just got to use your clinical judgment there.
Yep. And Steve, finally, do you have any take-home messages for the doctors, or any really important points that you'd like to bring out for patients with ocular injuries and orbital and facial injuries?
Look, obviously call us early, because the sooner we get a call, the sooner we can respond to the particular request. You don't have to have spoken to an eye specialist before you call us. If you have, that's fine, but if not, as soon as we know that there's a task, we can start planning and coordinating how to do it, and we can put people through our comm centre through to a specialist if they want. And I guess I would encourage everyone to, of course, work on preventive health measures, and in rural areas, encouraging your local buddy farmer to make sure he wears protective glasses when he's doing fencing and all those things.
And our thanks to Dr. Langford and all our guests in today's programme: Martin Shaw, Dr. Jean-Louis de Souza, Dr. Angus Turner and Dr. Olga Ward. That's all the time we have for this programme, but before we go, just a reminder that the Rural Health West Doctors Service Awards nominations are now open. There are 5 award categories that rural practicing doctors can be nominated for. The Rural Health West Doctor Service Awards is in its 6th year and is again sponsored by Wesfarmers. We encourage you to consider nominating a rural doctor whom you believe has provided outstanding or extraordinary service to their rural community. Rural general practices are also invited to nominate their practice managers for the Rural Health West Rural Practice Manager Award, sponsored by MDA National. Practice managers are an integral part of rural general practice, and we encourage you to publicly recognise the wonderful work your practice manager does. Nomination forms for both these awards can be downloaded from the Rural Health West website at ruralhealthwest.com.au. And while you're there, remember, you can review this programme or any others going back to 2009. We're back on the 3rd of September with a programme focusing on minor head injuries. I'm Jerry Gannon. Thanks for joining us.